Welcome. Welcome everyone to the May 15th Virtual Learning Collaborative, implementing anti-racist and harm reduction practices into elimination planning and viral hepatitis activities, made possible in partnership with the CDC's Division of Viral Hepatitis. So my name is Isabella Chuga. I use she, aya pronouns, and I am an associate director on the hepatitis team. Joining us today are presenters and moderator Chloe Manchester, who is the viral hepatitis coordinator with the Maine Center for Disease Control and Prevention, and also HepTAC consultant. The format for today's session is as follows. We will begin with presentations by Dziko Singelton, Bronwyn Barnett, and Kelly Bachiochi. Did I mess it up? Followed by presenters joining us from JSI, who were involved in the Northern New England's elimination planning. And then we'll wrap up the session with a moderate discussion led by Chloe. So feel free to use the chat to introduce yourself and your jurisdiction and for your questions. And with that, I am going to turn it over to Dziko.
Hi, everybody. Good to see you guys. I gotta admit, I was just explaining to everybody. I was like, what's the link? How do I get in? I can't get in, but I'm here, all is well. And I love talking about HepNET. So my name is Dziko Singelton. I am one of the consultants with HepNET Leading with lived experience. And the jurisdiction that I offered instruction and support to was New Hampshire. Never knew much about New Hampshire, except I was like, well, do any Black people live there? So this is when I started having to do a deep dive into the demographics in New Hampshire. And one of the things that really struck me was that in my Google search, it said that there was a 10% Black population. And so this is when I knew that, along with the amazingly brilliant people who work in New Hampshire in public health and in Hep C elimination, treatment and prevention, that we could come up with some really feasible outcomes for the work that we all do. And this is where my relationship with Bronwyn and the rest of the team comes into play. We just talked about things. I have a ton of experience in being a Black person. I have a ton of experience in being a person in recovery and a person who was an active IV drug user. And I understand that there are so many different resources and services that I wasn't made privy to. So it's my life's work to make sure that we lessen that. So along with Bronwyn and the rest of the folks who joined in on the sessions, we started devising different plans to figure out best outcomes to reach the people who deserve these services the most. So I'm super proud of our relationship. I feel like we really did make strides. I don't think we were looking to change the world during the months that we did these sessions, but I think we made some headway. So I feel really good about that. I feel really connected to the work that they're doing in New Hampshire because Hep C treatment is universal. I feel like we can reach the elimination goal. So that's a little bit of my backstory, I guess. And I think I'm turning it over to Bronwyn.
Sure, I can just talk for a couple minutes, I think, on kind of what the experience was like. First of all, as you can all tell, working with Dziko is an absolute dream, and it was fantastic. We had a really great group, and I think one of the things that Dziko really brought to the table, in addition to her experience and her wealth of knowledge, was she was a really good counterbalance to being able to have really big open-ended conversations where, sometimes I think in this work, we are very, and I'll raise my hand, are very outcome oriented. And some of the progress gets lost when things are so concrete in terms of how structured it is. But HepNet it provided a 6-month structure, an action planning process. I would say from the New Hampshire Health Department perspective, it was incredibly beneficial for a few different reasons. One of them is that we talk a lot about health equity. As Dziko pointed out, New Hampshire is incredibly white and we're a privacy first state. So it creates a lot of hurdles when it comes to doing anything and creating any plans around health equity. And so HepNET kind of provided us a structure and accountability to prioritize the work, and honestly, like the space and time to actually work with our partners on this. And then this is kind of a soft thing, but you know, because it was an application-based experience, I had to go through an approval process, and if it, with our chain of command and getting approval from leadership, it allowed me to get it on higher level radar that this was an issue that needed to be prioritized. And by approving my time to work on this with our community partners, which seems so very basic, but we have to be really smart with how our public health operates because of our executive council, and it kind of gave us a mandate to do things that we wouldn't otherwise be able to do. And it created a sort of a ripple effect within our section and our bureau where people were asking about health equity councils and things that kind of were maybe in existence before COVID hit and then just kind of phased out when key people left. So it really felt a little bit bigger than viral Hep. And yeah, I that's kind of a broad overview.
All right, we ready for some slides? I'm sure I can handle this. Okay. Basic slide deck. All right. Y'all let me know. How's it looking? Good?
Looks good.
Yeah.
Looks like what we sent you. Good is subjective. It's all there. So I think we're gonna, do you want me to just dive in?
Yes.
Okay, awesome. And thanks, Dziko. I think there's so much more that could have been said about that experience, but really, like, truly an honor to work with you. Okay, so I think we're shifting gears slightly to a collaboration called Hepatitis Free Northern New England, or Hep Free NNE. I think you've all possibly heard bits and pieces of this before, so we're not going to dive too deep into what it is. But I will say that what we prepared today is focused primarily on prioritizing harm reduction practices, because I still think we have a lot to do in terms of work on anti-racism in our Northern New England states. And we can definitely chat about that at the end in terms of like specifics around the challenges and what we hope for implementation. So next slide, please. Awesome. So this is a project involving 3 neighboring states who don't receive any additional state funding for viral hepatitis. So Chloe Manchester, your moderator today from the Maine CDC, Kelly Bachiochi, Kelly, we're terribly sorry with how we're pronouncing your last name, from Vermont Department of Health, and Alex, who contracts with them. They're all state co-chairs who we've all been working closely together since 2021 to get this project off the ground. And then last year, New Hampshire DPHS, we were able to use our unobligated funds from year 1 to expand our public health services contract with JSI CHI. And so we also we're very grateful to have them as part of our leadership team. So we have Jonathan, Emma, and Lauren, who have been key to implementing many aspects of this project. So if everyone on the leadership team would just come off camera and wave, that would be amazing. And I won't pause, but I would love that. And then I just want to acknowledge how helpful NASTAD, the VLCs, and the other states have been. I've never met many of you, but as a new member in the fall of 2021, the presentations, especially that September by Colleen Flanagan, sharing about the New York State process, Zakiya sharing about how you got things done in South Carolina, Thaddeus from Hawaii, Tennessee, and the Syndemic Plan, really studied those and made comparison documents to see what approach and styles could make sense for a regional approach. So I think that we are definitely standing on your shoulders. And, you know, as I mentioned earlier, we're focused on harm reduction right now, but we still have a ways to go when it comes to anti-racism. And I really hope that we continue learning from you all about strategies that have worked and what could be adapted here. So next slide, please. And then I'll hand it over to Kelly to introduce the project.
Awesome. Thanks, Bronwyn. Good afternoon, everyone. I'm Kelly Bachiochi. We both did great pronouncing my last name, so well done. So yeah, as Bronwyn mentioned, I think many of you have heard a lot about this project already, so I'll just give some very brief background information on HEP-free NNE, like who we are, what we've been up to, and how we're structured. Next slide, please. So yeah, so we've developed an initiative to develop a regional elimination plan across our 3 jurisdictions, which are the 3 northern New England states, Maine, New Hampshire, and Vermont. We decided to partner a couple of years ago at this point to pool our resources within our 3 small states. There's a lot of overlap in our patient populations and our healthcare systems. Our community-based organizations are often serving you know, people in 2 or more states. And we have really similar population demographics as well. Also, I just wanted to point out that our website is somewhat recently launched, hepfreennne.org. You can find a lot of information on there, including, you know, our mission and vision, our core values, our steering committee information, our planning group information, meeting minutes, plan timeline and progress and resources, etc. We're really proud of our website, so please check it out if you have a chance. Next slide, please. So you can see here what our mission, vision, and goals are. I'm sure they're very similar to what many of you are working on in your own states. So, you know, we really want to see all 3 states sort of free from viral hepatitis and envision Northern New England as a place where new hepatitis B and hepatitis C infections are prevented. Everyone knows their status and everyone has access to high quality, stigma and discrimination-free care and treatment. And our goal is to develop the first 5-year Northern New England Hep B and Hep C elimination plan by January 1st of 2025 via a community-driven iterative planning process. And this is the first time there will be an elimination plan for any of our 3 states. So this is truly the first elimination plan. Very exciting. Next slide, please. So our planning body includes both a steering committee, and we've been meeting for, I think, about 1.5 years now, although there's a core group of us who've been meeting for even longer than that, as well as a larger planning group of over 50 people across all 3 states, which really represents a broad range of stakeholders. We have people with lived experience, we have providers, correction staff, we have a director of hepatology, we have surveillance folks, we have people from Medicaid, we have drug companies represented, we have tribal health and harm reduction folks in attendance. So we're really proud of the diverse group that we've managed to put together for this planning group. And the group, as mentioned, is co-chaired, as Bronwyn mentioned, by the 3 state hepatitis coordinators who are all on this call. So the overall management is really overseen by Bronwyn, our fearless leader. And we do receive contract support through JSI, CHI, which we've already mentioned, which is funded through New Hampshire CDC Grant Award. We also receive support from Caracol Consulting, which is Vermont's HIV programs community planning subgrantee. So they are both really key partners in this initiative. Next slide, please. And I think it's back over to you, Bronwyn.
Yeah, so in terms of implementing planning priorities, next slide, please. So relevant to today's topic, you can see that developing a plan that was informed by people with lived experience was a priority from the get-go, as was making sure we are engaging in a process that was community-driven, meaning not stuck in the state health department's kind of echo chambers. And then ensuring that there were built-in iterative cycles to help us avoid getting stuck in that like perfection paralysis, or worse, like sticking with something that made no sense in the grand scheme as we kind of walked along this path. So building in a lot of flexibilities. Next slide, please. So I just included this slide as a visual for what I mean by iterative process. So you can see we have the circular leadership team / steering committee arrows in between larger planning group meetings. So basically we gather our evidence, we listen, we test, we tweak based on feedback, and we rinse and repeat. So this is just one example, but it's threaded through the process in other ways. Next slide, please. So these are on our website, so I'm not going to read them, but you really can't talk about prioritizing harm reduction and planning without talking about priorities in general, without calling back to your core values. So these were drafted early on before our steering committee officially kind of formed. I would call it like steering committee 2.0. And then we went through an adoption and editing process when we formed our charter, made sure everyone was on board and understood what grounds us. And I'm very like nonprofity, that is my background. And so I've always believed that core values are one of the most important things in any organizing effort, because they create a shared identity, they help prioritize your resources, they're a vetting process, and they have a direct impact, most importantly, on your budget and how you spend your time. So if you and your group are unclear about your core values, everything else is just a lot harder. You can see that harm reduction is explicitly identified, as well as the principles of harm reduction to which we subscribe. You can see that intersectionality is called out, as well as non-traditional partnerships in this endemic approach. And again, so much of this aligned with the HEP network, which is part of the reason why I was so excited about the opportunity and the overlap there. Next slide, please. So we identified and adopted our core values, and then, which are essentially our priorities. And then, of course, the big lift was to make sure that they're in the budget. So budgeting is where kind of your priorities either live or die. We set aside $21,000 from the New Hampshire PS21 budget, added it to our contract budget and a community engagement line, and it just gave us that much more flexibility in spending. And then made sure that that community engagement was embedded as a continuous activity throughout the process. So I want to say that we do have people with lived experience in Hep C treatment on the steering committee, but we don't call back to them. We don't, identify, or like, there's no like tokenism with that. We know we need to reach beyond that one person to speak on behalf of, it's not a monolith here. But so continuous kind of community engagement was definitely a priority here. And within this, we specifically included funds to provide stipends and set up MOUs with community-based organizations. And I can't tell you how many times over the past couple of years, I've heard, pay people for their time, especially with harm reduction programs and people who use drugs. I'm sure this is true in other states, but in New Hampshire, we passed a law in 2017 to allow SSPs, but we specifically said we will offer no state funding to support them. And I'm paraphrasing very poorly, but we're like, yes, you can do this incredibly important work. You can have the honor of being trusted partners to people who have been systematically excluded from traditional healthcare, whose lives are no less important than anyone else's. You can provide instruments to help decrease transmission of disease, but we're not going to make sure you have the resources to do your work. So when we are talking about engaging these people in our constituents and our community in this, we really want to make sure that there was payment was included. And so that was definitely part of it. I hate talking about budgeting, but I also love talking about budgeting because that really is like your intentions materialized. And the second part of this that the JSI team will speak to in more detail is because we're planning to survey and engage people with lived experience who of course should be treated ethically and with kindness and like people who matter just as much as anyone else, which is kind of the point of all of this, and be protected from research related risks. We went through a IRB approval process before engaging in outreach. And I want to say that ideally, right, people with lived experience would be leading this process as co-producers and architects in the planning, but we were not and are not at that ideal state. We were and we are doing what we can with the relationships that we had at the time to make the progress. just acknowledging that we weren't going to wait for things to kind of be this perfect setting before moving forward. So there's still like a long way to go. Next slide, please. So to that end, we were able to launch multiple lanes of outreach and listening sessions, which really helped inform the first Northern New England situational analysis, and ultimately provided the qualitative data that helps shape our initial goals and objectives. And to be clear, as Kelly mentioned, we also have a larger planning group spanning 3 states. We have the smaller 30-ish person steering committee member, as well as a leadership team. But we know that not everyone can make Zoom meetings, and nor would that modality always be perceived as welcoming or an accessible environment to many. And so we just were focused on creating several pathways for people to engage in planning. And you can see it in the numbers. So engaging people with lived experience is the focus and priority of our community engagement. Next slide, please. So this just provides a little more detail. I'm not going to read it because Jonathan, Lauren, and Emma will talk more about this and what we learned. Next slide, please. And then just some additional detail on the other engagement pathways. Something I do want to point out is that we established discovery committees, which were subcommittees of the steering committee. And they were established to explore complex, politically fraught, or sensitive issues that have the potential for maximum impact on hepatitis elimination. And so 3 DCs were established: Medicaid partnerships, Hep C care in correctional settings and reentry, and perinatal Hep C care. And so over the course of 6 months, about 34 stakeholders were engaged during about 25 listening sessions, and the findings were integrated into the plan and presented at the kickoff summit. Next slide, please. So these are the goals that came out of all that work. You can see that harm reduction is a big piece of this. And we're now at the point where our objectives are drafted, and we're moving on to the specific activities, kicking that off tomorrow. So the practical concrete actions to help us achieve each objective. And so we're very excited to move past that 10,000 foot level to where kind of the rubber meets the road. Next slide, please. So just a few considerations before handing it over to Jonathan. Next slide. Or Lauren, sorry. Jonathan or Lauren, you're on the deck, one sec. So a few things. So core values drive your project management, whether you recognize it or not. So being explicit about this and referring back to them often changes the game from kind of herding cats to rowing in the same direction. Again, super nonprofity, but a shared identity grounded in your core values makes a big difference on so many levels. And if your Department of Health leadership approves them, it also gives you a bit of a mandate to double down on specific activities that may be uncomfortable from the Department of Health standpoint, but completely necessary. So consider it also a way to get approvals for what you want to do and what you believe is right to do based on the evidence in your state. Next slide, please. Money matters, so how you spend it matters. People can do a lot of talking about their values, but if you can't see the values in the budget, it's hard to feel like your intentions will produce tangible outcomes. So when people share their work around viral hep, I always want to know how it's funded. I come from a state where the only funding for viral hep work is through our cooperative grant, as I'm sure many of you do. And up until last year, we didn't have any additional partnerships supporting the work. We have this thing called Executive Council that I'm not going to get into, but it makes it to the point where spending money is actually almost harder than getting it. And it always takes longer than you want, like 6 to 9 months. And then sometimes things just blow up at the end. So going after new funds are even a bit disincentivized in some ways, but it really is worth the time to make sure your unobligated balance is spent. Like, don't leave any money on the table. Be really discerning about your line items and how you're spending it, and see what contracts you already have that could be expanded. And I saw a question pop up in the chat that I think Jonathan is going to probably dive into shortly. Next slide, please. Tips: make your budget work for you. Don't leave money on the table. Review existing contracts within your health department to see where these priorities could be added as line items, really specifically looking at harm reduction and anti-racism, and know who in your leadership you need to get on board and do it early, and see if there are little kind of approval benchmarks that you can create along the ways so that you have a mandate for your activities later on. Next slide, please. And outside of using your budgets to shape your work, always also, focus on leveraging what you already have. We talked a lot about this in HepNet and building on the assets and the partnerships, but also, ask yourself, are there existing contracts or work plans that could be expanded? Just a couple examples, our public health contract, took about 9 months, but we were able to be really a lot more creative and flexible with our spending, especially when it came to setting up MOUs with community partners. We maybe could have done this through the state, but our contracting process is so protracted that it would have taken a year to set those up and been incredibly fraught. Whereas JSI it felt like, Jonathan, you guys did overnight. We also integrated viral hep in our HIV plan, so using HIV funds to cover the cost of hosting and maintaining our NNE website. Cancer programs, this is just another example. So, I attended the National Comprehensive Cancer Control Plan Conference as a way to kind of leverage cross-bureau funds from our Bureau of Prevention and Wellness, where the cancer program is housed, to validate dry blood spot testing for viral hepatitis in our public health lab. So we've purchased materials, we're working on a pilot that's happening now without requiring funds we don't have from PS21. And the best thing is, like, I don't have to report on them because the funds are going from the labs to the Bureau, and I just have to manage and support the process for happening. So that's kind of an ideal state. And then Kelly can speak to this last example.
Yeah, so we at the Vermont Department of Health, our HIV, STD, hepatitis program, we are really fortunate to have Alex Potter from Caracol Consulting, who supports our work in HIV and STI. And I realized I used the wrong terminology when we were developing these slides. He technically is a grantee of ours. He has a subrecipient grant with us, not a contract. I think he used to have a contract, and it's very nuanced how that all works. So, but we basically, he has worked with us for many years. He provides a lot of administrative support for our community planning. So he helps run our community advisory group meetings. He helps us with grant and report writing. He has done our HIV needs assessment and comprehensive care plan. He's just a wonderful human being with so many perfect, like truly the perfect skill set to help us with this project. So we expanded the scope of his work to include hep-free NNE and elimination planning using our 2120-103 surveillance and prevention funds. So, and I think we can all agree that Alex has just been such a huge add to this project. So being able to expand the work of this person who already, has shown such really truly the perfect skill set for this work was just a wonderful thing to be able to do. Just capitalizing on those pre-existing relationships was really huge.
Yeah, that's great. Thanks, Kelly. And I think now we're going to kick it over to JSI, who can talk more about the technical side of things. So next slide, there you
go. All right. Good afternoon, everyone. I'm Jonathan Stewart. Appreciate the opportunity to share with you some of our efforts here in Northern New England to engage people with experience in our planning process. I'm going to take a few minutes to review process implementation considerations for accomplishing that goal. And then I'm going to turn it over to my colleagues to share some of the important themes that have come from that work. If you could go to the next slide, please. Thank you. So as Bronwyn mentioned when she was describing our planning priorities, a first level early consideration was that we wanted our planning process to be community driven, continuously informed by people with experience and the organizations who provide service to us. And an important aspect of being true to those values, at least in our thinking, was that we didn't want to just drop in on direct service organizations with a bunch of our own questions from people unknown to their clients. Rather, it was important for us to kind of work behind the scenes in partnership with community-based organizations. Organizations already have relationships built on trust, on openness and flexibility. And in particular, our initial emphasis was on engaging people who are clients of student service programs across our region. So having relationships built on trust was really critical and essential to the process. It's also important that our process was not burdensome. We fully recognize the organizations that we were working with have their own needs and priorities that would always take precedent, pressing everyday needs beyond what we might be hoping for in terms of collecting information to inform our planning process. But we also needed to, while designing a process that was not burdensome or rigorous, we did have certain ethical and financial fiduciary responsibilities that we needed to attend to as well. And if you could go to the next slide. Bronwyn mentioned we knew from the beginning we needed to go through an institutional review board process. And the organization I work for, JSI, it's a relatively large public health consulting group. And that's relevant here because JSI maintains its own internal IRB. And we have our own requirements to approve any activities that involve data collection from individuals. So while what we were doing would not be formally classified as research, the potentially sensitive nature of the subject matter, the likelihood of engaging potentially vulnerable populations, it was imperative that we go through the process of an independent institutional review of our methods and proposed procedures. And that included review of recruitment plans and materials, our consent procedures and forms, our question sets. If you've been through an IRB process, you know how that is, and it's an important step in the process to assure ethical approaches to what we're doing. So some key elements of the package that we prepared an expedited review, and part of that was we needed to assure that only adults were eligible to participate in the discussions. There was no identifying information that was collected at all. And as part of that, we needed to get a waiver of written consent. So such a verbal consent was okay, because we didn't want to have to require people to provide signatures on documents, for example. And our questions were intentionally designed to not directly ask for personal history or medical history. And I'll show some examples of some of the questions in a moment. But another important point I would emphasize here is that before we went to the IRB, we worked with several of our existing community partners who we knew were going to be part of this work to review our questions, to review the process and procedures in advance to make sure they were appropriate, that they were feasible. So essentially there was a community-based reality check before we even went with our ideas to the IRB, and that was super helpful and helped to expedite what we were doing. Next slide, please. So some interview format content considerations. We actually ended up developing 3 different protocols, one for individual interviews or discussions, one for group discussion, one that would enable an organization or a person to anonymously call into an organization to engage in the discussion. Most of the data collection did end up being individual interviews, but we wanted to make options available to our partners at their discretion. The questions, I don't know if you can see those on the screen, but they were designed to be flexible. Mostly they start with what do you know or what have you heard? So again, we weren't asking for personal histories. People could volunteer that information if they chose, but we were directly asking people to prove their histories. The most important question, I think, probably is the one, so what do you think we can do to improve? That's the key question for me. And we certainly got rich information through that process. And again, our goal was to enable space for meaningful engagement. Our partners could deviate, following the lead of clients or people engaged in the discussions. It's not tightly scripted. We wanted to allow that space for people to share whatever they wanted to share, and that was really our most important goal. Some additional factors, variable across organizations, was the ability to conduct interviews privately and confidentially, and particularly in community outreach settings. And related to that, staff capacity is a big variable. Some of our organizations are pretty lean, particularly the syringe programs, have limited staff in some cases. So, carving out time to do interviews in addition to the harm reduction work, we had to have, and we did have reasonable expectations around that. We were to sort of honor what people have on their plates. And we didn't set particular expectations around numbers of interviews or timelines. When the work was going to be done, it was really up to the organizations to go with the flow of what was going to work for them and for clients they were serving. And that's really the most important consideration, I think, was trusting our community-based partners to really know what was going to work best in their settings. Because we certainly have shared goals, but we were never intending to sort of interfere with what they were accomplishing in their important work. If you go to the next slide. So as Bronwyn mentioned, we had memorandums of understanding were the form of our agreements that outlined purpose, roles, and relationships, some of the key needs around the IRB in terms of how consent would be done, things like that. But we intentionally did not have subcontracts, which was an important point in terms of the flexibility. We didn't require specific deliverables or targets. We didn't require financial reporting other than we needed to have an invoice. That was it. Just an initial invoice. And in some cases, we actually prepared the invoice for our partners. But generally, the idea we had limited. Most of this work was done over last summer in advance of a summit that was coming up. So we were trying to move pretty quickly. We did find that our smaller organizations were able to process MOUs to make that agreement much more nimbly than some of the larger organizations, particularly governmental organizations. We had a few local health departments we were hoping to work with that in the end weren't able to get their agreements through their internal channels. And so our very grassroots organizations were the most nimble, but the other side of the coin of that is they also have the most limited staff capacity. So that's the challenge: nimbleness, but needing more capacity for sure. The funds we provided were small, relatively small. It's $2,000, but they're provided in the form of a stipend, so organizations could determine for themselves, how you want to allocate these funds towards staff costs, other operational costs. Gift card incentives did come out of that. Organizations could, within a range, determine what they thought would work best in their setting, but again, we didn't require any financial reporting because it was a stipend. So here's some funds. The purpose. We're here to support you how we can, and go. So that was pretty much it. We did end up with 8 organizations overall so far, a mix of organizational types. Initially, we were focused on syringe service programs, harm reduction programs. We also had an FQHC with a pretty robust viral hepatitis program. We had a family planning agency, and LGBTQ Community Center Vermont brought an important perspective, different than the syringe program. So that was a key partner. And the last one is interesting in that there was a seasonal warming shelter that heard through the grapevine what we were up to and reached out to us and asked to be part of it. And that just happened just within the last couple of months as winter was winding down. We sort of scrambled and got some resources out, and it was great to have another organization primarily focused on people who are unhoused, and that was also important perspective. Next slide. So just lastly, a few other implementation considerations. And by implementation, I'm now talking about the actual engagement in the interviews, discussion processes. I think I've already emphasized the need for flexibility. We brought almost no expectations other than please work with us. It was our main expectation, and share information will help the regional planning process. And so a lot of flexibility around that. We had some organizations that provided us with extensive notes, others provided brief notes. So again, it wasn't research. Any input was meaningful. It was all about engagement, opportunity for input. Any input was great. We did work with a deadline of our own of sorts because we had that summit in October, and we basically had just a couple of months to gather as much information as we could to help inform that summit. But that was not a hard cutoff. organizations continued past that point as they were willing to continue to engage, and we're hoping that throughout the whole process of planning into implementation will be a continuously community-driven process, as we've described. And then my next slide, I just would share a little bit of feedback from our participating organizations. It was gratifying to hear that was not only helpful to us, but helpful to our partners. There's one there in the top one. This has been an unexpectedly interesting and rewarding endeavor for us. So I really appreciated hearing that and hearing that the information through the discussions was not only helpful to us, but also helpful to people in the field in terms of designing their own work and being responsive in their own work that is helpful to them as well. So I think overall, our original intent of being sort of behind the scenes, engaging partners in the form of organizations to do some engagement, I think that's been very fruitful. Our partners, I think, for the most part, enjoyed being part of the process. So I think it's been good. And now I'm going to turn over to my colleague Emma Gertz, who's going to share some information, and Lauren will share some information about some of the themes we've found.
Okay, thank you, Jonathan. So as he said, I'm going to go over the data that was gathered from the interviews with the aforementioned organizations. As Jonathan mentioned, we ultimately collaborated with 8 organizations from across the 3 states of Maine, New Hampshire, and Vermont. This included 3 in New Hampshire, 2 in Maine, and 3 in Vermont. Notice there's an asterisk next to the Warming Center of Stratford County. As Jonathan just mentioned, this is because this organization signed on to participate recently, and their data will not be included in the current analysis that we'll be talking about today. But for today, a total of 135 unique interview responses were thematically analyzed. Next slide, please. Okay, so the 3 main themes that were identified through the analysis of the interviews were increased and improved services, education and awareness, and testing and treatment availability. The interviews were analyzed chronologically, so some of the participating organizations signed on later in the process. Those interviews were analyzed as well, and most of the themes remained consistent. However, some standout information rose to the surface from those, and we'll address that later on in the presentation. Next slide, please. Okay, so here we have a quote pulled directly from one of the interviews that we felt exemplified the theme well. And you'll see these throughout the slides, but I'm going to go ahead and read them. Actually, it's not coming up here, so I'm just going to read it. There it is. Services in general, especially right now, are really limited and hard to come by for old guys like me. I'm living in a tent in the woods right now, sleeping on some couch cushions I found. I didn't even like camping when I was a kid, but what can you do? You're the only one who has cared enough to sit and talk to me and even ask how I'm doing. I really appreciate you checking in on me. Okay, so diving into the sub-themes, we have care expansion, which includes the desire for more services and touch points through which to access the services. And this includes an overall greater interaction with healthcare service providers as well. There's the desire for extended clinic hours. So not everyone has a flexible schedule, and getting to a clinic during opening hours could be difficult for folks. Transportation can also be a barrier here, which we'll speak more on later. And then a desire for more PCPs. So finding a PCP in the first place is difficult, and staying with the PCP is really hard for folks as well, from what we heard. From what we found in the situational analysis that we did as part of this work, we found that there's very long wait times to get into a primary care provider in Northern New England, and that also makes it difficult. There's also non-hepatitis related to healthcare needs that came to the surface. So many hepatitis related care needs are lower on the list when other health issues are competing for priority and need to be addressed as well. And then there's preventative services and basic needs. So this includes things like housing, mental health care, food, wound care, etc. Again, when basic needs are not being met, hepatitis testing and treatment fall to the bottom of a person's priority list. And then there are services specific to people who use drugs, and this can include Suboxone and methadone treatment clinics, syringe service programs, harm reduction services, and reintegrative support. There's also a need for better patient engagement at all of the locations I just mentioned, and including healthcare system locations as well. And there's an enhanced trust in the community non-healthcare organizations, so those that conducted the interviews for this portion of the project. there's also a great appreciation for and utilization of those community organizations. And there were a few of them that were mentioned multiple times by interviewees. One of them is the Discern Van. So this is the Drug Injection Surveillance and Care Enhancement for Rural Northern New England. It's a project aimed at expanding access to testing and linkage to care for underserved and high-risk populations. This initiative is currently operating around Brattleboro and Keene, and it's equipped with clinical staff and harm reduction supplies for outreach to people who use drugs. It's part of a federally funded clinical trial to demonstrate the effectiveness of mobile and telehealth services for people who use drugs that are living with viral hepatitis. And there's also the Listen Center. This is located in the Upper Valley of New Hampshire and Vermont. And it's an organization with the mission of providing individuals and families with the resources they need to feel safe, fed, and housed. There were some complaints that arose around services that were not meeting the needs of the community, but within the same breath, people were recognizing that this is likely due to underfunding. So really, it's an appreciation for these organizations and a desire for more of them and more of these services. Next slide, please. All right, so a couple more quotes here. There should be peer-to-peer support and having more people who are positive speak out about their experiences and education about the pros and cons of waiting versus going for treatment. When he was dying, I was trying to get as much info as I could to help him, and the doctors didn't want to help him because he wasn't sober and they said he didn't have a chance. So diving into the sub-themes here, we have education for communities and individuals. So many interviewees' awareness around Hep B and C came from personal experiences or anecdotal evidence from folks that they know. Interviewees had a general knowledge of hepatitis, which included the fact that it's a bloodborne pathogen that affects the liver, that it's transmitted through bodily fluids, which can happen by sharing injecting equipment or having unprotected sex. And most people were aware that testing and treatment options are out there, but the specifics were not always known. Some people were aware that there are treatment options, and a significant number of interviewees were under the impression that interferon remains the primary form of hepatitis treatment, which, as you can imagine, likely doesn't inspire people to go and get treated right away. There's little knowledge about the vaccine. Some folks know there's a vaccine, but were completely unaware of their vaccination status. And an even smaller number of people were required to get the vaccine for work purposes. But again, that was a very small number of the overall people interviewed. And then many interviewees expressed a desire for better education on viral hepatitis, including more publicly available information on their options for testing and treatment. And something that people noted multiple times was quote unquote TV advertisements. Provider supplied information. So there's a desire for more providers to start the conversation and initiate linkage to care, and for PCPs to encourage and facilitate testing and treatment, and just normalize talking about viral hepatitis. People don't want to have to go into the doctor's office and bring up the conversations. They want this knowledge to be brought to them. So proactive instead of reactive treatment options. And then there's also education for providers. So providers don't always share the information up front about viral hepatitis, and this includes risk factors. People want to hear more about this. And there's still provider stigma out there. So there's a lot of unwillingness to treat people who are actively using. Another sub-theme is insurance. So a lot of folks don't know what's covered by insurance. A lot of people have Medicaid, Maine Care, et cetera, and they're hesitant to go into the doctor because they don't know if they're going to be hit with a huge bill afterwards. And then another barrier here is that a lot of folks don't have insurance. And then going back to stigma, there's a need for better public education about people who use drugs and are living with hepatitis. There's a need for increased services for underserved and high-risk populations. And then something that rose to the surface, a few people mentioned that in rural communities, which in these 3 states, there's many rural communities, that everyone knows everyone, and it discourages care seeking around viral hepatitis because people don't want to be stigmatized. And I will pass it over to my colleague, Lauren, to present on the next few slides.
Thanks, Emma. So I'm going to talk us through the last major theme, which is testing and treatment accessibility. The first pillar there, actually, if you just click one more, we do have a quote to lead into it. If there were more places for people to get tested, like at the harm reduction program or pop-up clinics like flu shots, It takes so long to get into a doctor around here. Every couple of months, it feels like we have to find a new PCP. And we chose this quote because we felt it accurately represented the struggles that people living with hepatitis continually face. And so that is encompassed in these three sub-themes here: community outreach, transportation, and healthcare. The first, community outreach, basically how we sum this up is that people want to be met where they're at, and right now that's not happening. And this can, we see this both emotionally and physically. You can't make people get treatment they're not ready to receive or to go through. And so that's why there was a lot of appreciation for the people conducting these interviews and going to talk to them. There was a lot of appreciation for, and there was a high use of mobile testing, such as the Discern van that was already mentioned. And a few people asked if there was a possibility of having take-home tests or something of that sort. There was also a high engagement in testing and treatment at locations where high-risk populations already frequent, such as community centers, SSPs, AIDS and HIV resource centers, shelters, harm reduction organizations, and family planning centers. So this just shows us how community is really important in this work, and how that means a lot to people who currently have hepatitis. Transportation is also a significant barrier in accessing care, especially in rural areas, and that is something that should be considered in the three states, Maine, New Hampshire, and Vermont. People mentioned bus routes, and while they're available, they weren't far-reaching enough to really get them to the appointments they needed to be at. And there were some suggestions for individualized transportation, such as shuttles that would go directly to a hospital or to a clinic so that people could get to their appointments easier. Because it's not just about getting to the appointment, but it's also the time it takes to get there. And there's a lot more components that build into the transportation issue as well. And lastly, there's healthcare, which really starts to get at the broader healthcare system. And the main takeaway here is that we see how previous interactions with healthcare services really impact the future healthcare seeking behaviors of people with hepatitis. And as Emma talked about stigma earlier, when people are met with stigma with PCPs or in talking to people, that really discourages them from seeking testing and treatment in the future. And so what this results in is a preference for non-traditional healthcare services, such as the community locations we mentioned above, and including the places where all of these interviews were conducted. We also saw positive experiences of people interacting with mobile testing sites and telehealth as well. A small number of interviewees were aware that telehealth and mobile testing clinics were available as an alternative to traditional in-person healthcare services. And the people who used these modalities for testing reported high ease of access, which is what we're really wanting to see. Maybe you could go to the next slide. And then lastly, this is a bunch of sub-themes. So as Emma said, not all of the interviews came into us at the same time. So we had already begun conducting the analysis while we were still getting more interviews in. And while a lot of them did align with the themes we had already pulled out, there are a few smaller ones that sort of build on the broader concepts that we've already introduced and are still really important in the broader lived experience landscape. So the first one, which we've introduced before, but just to reinforce it in a slightly different way, is an emphasis on insurance as a barrier. A quote that I pulled out says, "I would not have had labs drawn or known anything about my status if I didn't have insurance. Having access to health insurance is the key." And so it's not just about having insurance or not having it, but it's also about knowing how to use it and being able to use it. So it's a much more complex issue there. And these experiences of being able to use it will encourage people to seek testing and treatment in the future. The next one is a call for prevention and intervention for youth. We've talked about stigma several times already, and since this is built on and like exists within communities. Stigma trickles down to kids, whether that's through their parents, their friends, other influential people in their communities. So it's important to teach them the facts and importance while they're young. And also knowing the risk factors that can lead someone to get hepatitis. As these activities are becoming more common in younger demographics, that just reinforces the importance of teaching them these healthy habits earlier on, encouraging them to get tested sooner rather than later. Positive feedback from interactions with PCPs at healthcare centers. So while a lot of people had negative experiences either with PCPs or getting one at larger health institutions such as hospitals or other clinics, the services they received at community health centers and the doctors they interacted there showed them a lot more care and helped them feel a lot more supported. So this shows us that there is a way to have PCPs and doctors help these people get testing and treatment without conveying stigma. And that is something that we can learn from. Supporting minority groups and disproportionately affected groups. And this sort of gets at the idea of making people feel comfortable while they're getting testing and treatment care. And the ways we can do this is not just by going to them and helping them out, but also increasing the local and community knowledge. And since community is so central in this analysis and in the interviews we conducted, knowing what resonates with people in a community and giving them the support they need without coming in and just enforcing our own ideas is important there too. And then the desire for more publicly available information. This came up almost the most, and it fits in with the education and awareness piece. But when we asked for what people wanted to see, so many of them said news articles, flyers, social media, posters, pamphlets, and in places like a grocery store or in a doctor's office, just to put it out there as much as you can. And this could convey just things like symptoms or what to keep out for, but also telling people where they can go for help or advertising harm reduction sites or clinics where they can go to get care and testing. And people said they want this just so they can know about it, but also to start a conversation and work towards reducing stigma within their communities. And then lastly, Jonathan touched on this at the end of his section, but appreciation for the people conducting the interviews. This is best summed up by a quote from one of the interviews. "You're the only one who cared enough to sit and talk to me and ask how I'm doing. I really appreciate you checking in on me." And this is sort of the crux of the people with lived experience analysis and why we put so much time into conducting the interviews and the analysis as part of creating the elimination plan. And it's because these people want to be seen more than just having hepatitis. And that is the crux of what we're trying to deliver, especially with the stigma piece and with the elimination goal in total. And that's given us this sort of comprehensive analysis. And the way we're integrating it into the plan is as we're coming up with the objectives and the activities within the New England Elimination Plan, as part of the iterative process, we're checking it by all of this analysis work that we've done before to make sure what people with lived experience have said, feel, and what they want to see is accurately represented by the information and the ideas that we're getting from our largest steering committee and planning group to help guide us towards having the most effective and successful elimination plan. That's all I got. I'm not sure who's taking over next.
Okay,
but...
I think I was waiting for that slide. Okay, so Lauren, that was an incredible overview. Thank you. And you know, as you can see, it's a lot of work. I think I'm supposed to provide a little wrap up here, but I wonder, given the sake of time, if we jump right to some questions. Would that be okay? Questions in the chat. I'm going to take silence as yes.
That works for me.
Okay, awesome. Do we want to, I mean, I'm just going from bottom to top. And Lauren, you've been up on deck, so I wonder if you can just speak to how the thematic analysis was conducted. Just a snippet overview of that process.
Yeah, so we used a trusty spreadsheet and we put all of the responses. Yeah, you can also look at Emma's message in the chat, but we put all of the responses into a spreadsheet, and Emma and I went through them, read through all of the responses and highlighted different quotes that stuck out to us and picked out main themes from each question and overall. And initially we did this separately. And then once we had come away with a few big themes independently, we came together and then walked through the takeaways we each had from it. And we used a Miro board. I don't know if anyone's familiar with that, but I'm a big fan. Really helps you organize a lot of big ideas. But from then coming together, Emma and I sort of compared what we both had and talked through, if we had the same idea, but maybe we phrased it in a different way, how we could make that make sense in one theme. And also she picked up on some things that I didn't, and vice versa. So we made sure that each of our ideas were representative and not repetitive. And then as the new interviews came in, we went through a similar iterative process to figure out which information fit where best. And I don't know if you want to add anything to that, Emma, but.
No, I think you definitely covered it.
Lauren and Emma, I'm curious, did you go into it with some pre-formed themes, or you went in, let the themes emerge themselves?
We let the themes emerge themselves. And in full transparency, I'm very new to the world of hepatitis care and elimination and all that. So I definitely went in with a blank slate and let the interviews do the talking.
That's almost better because you're unbiased. Yeah. All right. So I think we have until 4:50 officially, and I think as Isabella said, maybe if we have stragglers who want to hang on after to keep discussion going, we can probably do that. We have some discussion questions. I will keep an eye on the chat if anything else comes in. I think all the questions that were answered or asked have been answered already. Bronwyn, you raised your hand, but you're muted.
Oh, I think that there's one more, the criteria for individuals participating in the interview.
Yes, thank
Jonathan,
you for that.
yeah.
Liz had that question. Yeah. Jonathan, do you want to take that one? So what was the
Yeah, there
criteria
were,
for
so
individuals
I
participating?
mentioned in terms of the IRB, the only criteria, the only exclusion was that people needed to be adults, because we had no mechanism to get consent for minors. Other than that, the only criteria was that the individuals engaged were somehow or other receiving services from the partner organizations. So essentially our criteria was decided by our goals for the organizations we wanted to engage with. So as I mentioned, at the beginnings, syringe programs was high priority. We did a lot of outreach. I didn't mention we probably tried to engage 2 or 3 times as many organizations as we actually were able to pull together. But I think the criteria was defined by the organizations that we were able to engage in the process.
Thanks, Jonathan. So yeah, keep questions coming if you have others. Just pop them in the chat. So
Actually, Cliff, I could just add. So what that meant,
please.
The people who participated, some had lots of information and knowledge, and some didn't have weren't informed on the topic much at all. So which I think that was really constructive to have a range of perspectives that way. I'm sorry. Go ahead.
Okay, thanks. Do we still have Dziko on the line? The first question is about the HepNET learning community. So I'm gonna kick that one to Bronwyn and Dziko. Perfect. Okay, great. So starting off with your participation in HepNET. So before we get into this question, I wanted to sort of get your perspective how do you define, or what does it mean to you to meaningfully engage people who use drugs and center harm reduction in your work? Dziko, if you want to go first, and then Bronwyn.
Of course, I can answer that. So I identify as a person with lived experience. I'm in long-term recovery. These programs and services and resources mean the world to me because there was nothing like this in existence when I was still in active use. I just try to provide the support and the helps that I needed so desperately that I did not receive. So whenever we meet community partners or just people in my personal life who do the same work, I'm totally engaged. I do deep dives into it because we just want to make sure that people receive universal drug user healthcare, just healthcare, compassion, which is why HepNET means so much to me. We're a really small group of really dedicated people. So when we meet other folks like New Hampshire, I think Houston, Texas was another one of the jurisdictions involved, and you meet these like-minded people, just passionate people who care so much about the populations that we serve. It just makes everything that I do make sense. We see way too many people who aren't privy to just that. Yeah, Idaho was the third member. Thank you. We see way too many people who unjustly don't have basic health care needs. So this is why this is so important to me. Just all the input and just all the discussions that were had. Bronwyn and I have talked until late into the night, sometimes text early in the morning. And that just proves the dedication and the passion behind this. I know passion is a word that gets tossed around really freely and cavalierly, but it's just true. I think that when you approach this work with that type of advocacy and tenacity, you just see the results. I really do feel like when we go out and test with my team, I'm a coordinator for a harm reduction program here in Virginia. When we go out and if we only test one person, I feel like we've done our job. You know, not everyone is really willing to make that step, but we're in position when they get ready for it and we can meet them where they are. So I hope I answered that question. I answered this a lot of different ways. I just really do feel like advocacy is at the heart of what we do. And yeah, this has been, working with New Hampshire has been really, really made my heart full just to get the updates and just communicating with Bronwyn and the other folks in the cohort. This has been why I do what I do. So that's my long-winded
Great.
response.
Yeah, no, that's great, Dziko. Thank you. It's nice to hear that. Bronwyn, yeah. So first of all, how would you define what it means people who use drugs and center harm reduction in how did the HepNET Learning Collaborative help to achieve that?
I think I talked in the beginning a little bit, but I think the like echoing everything Dziko already hit on. But I think like learning and listening from Dziko and others, like that was a big part of it, is just like meaningfully engaging people. It's just kind of listening, treating people like they are the subject matter experts, which they absolutely are. I sit in a cube most of the time during the day or at my desk at home. And so I do not consider myself a subject matter expert the way that, the people who are experiencing things in real time and in real life with all the other things going on are. Providing multiple pathways for people to engage in the work. I think that's really, really important. Not doing like one and done stuff, just as Jonathan hit on multiple times, like just being really flexible and really grateful for anything that people can offer. Making sure the language we use is welcoming, which that's always an evolution. And I feel like I'm always kind of looking back and being like, oh God, like, that was pretty terrible. Like, how can we do it better next time? So that's, I feel like, a constant like learning process, and being really explicit about your like values and really leading with your values. And that to me is like the core of all of this, and just expanding that message. So yeah, I think that's it for me.
And I know at the top of the call, we talked about how this presentation discussion would be more focused on the drug user health and the harm reduction side of things rather than the topic of anti-racism. That said, something Dziko said at the beginning really resonated with me in that you said you're not looking to change the world. And I think it's for me that, because when we think about these huge problems and these huge obstacles in our way, I think a lot of us, and I think we feel like if we can't, we're failing. So with that in mind, I'm curious to hear what your thoughts are, either on big picture or something more incremental when it comes to anti-racism. Some ideas for the future, or ideas something we want to work on. Bronwyn and I and Kelly, we've been chatting a little bit about like opportunities to look at our data and understand better our race and our population, but just like quick ideas, quick thoughts, so that that's out there in the ether and we hold ourselves accountable to addressing that in the future.
Who are you asking this question to?
Go ahead since you're unmuted, and then we can go back to Dziko.
Oh, yeah, I mean, I really think we need to start with our data. It's really hard, Chloe, we've talked about this before, it's really hard because our populations are so largely white. It's really hard working with our surveillance data and just to talk about things, because there are things that we just can't say because our numbers are so low. And so we really, on the state side of things, really need to figure out how to communicate that this is a priority when everyone wants the data and the evidence to back it up. And sometimes it feels like our hands are tied. So that's one small thing that sometimes feels like an excuse, but it's like one little cog. And I think the bigger picture, and there's a much bigger picture and conversation around this.
I hope I'm going to answer this correctly, because I think it's a really complex question, and I think this is super conversation driven. I have always resisted offers to participate in DEI initiatives. I'm like, it's not my responsibility to teach a non-Black or non-brown person how to treat me. But this interested me. For whatever reasons, I think that the way that Jasmine, Cass, Nick, and Tina, the cohort trainers, presented this work to us, that I was like, well, this is necessary. This is really necessary. I think some areas I stay away from because, like I said, it's not my responsibility to educate certain spaces. This space was important to me. I've been denied basic healthcare treatments before, and I know that this was based largely on the way I present. I present as a Black woman, and you can just feel it. I can't really explain it, but you can tell by the inflection, the cadence in the conversations in these medical settings. Medical infrastructures are super racist and super biased sometimes. So I think this space I was really, really willing to be a part of. And we've seen some beautiful results as a result of the work that we all came and put forth. I gotta say, HepNET has been this oasis for me. I am a Black woman who co-coordinates the largest harm reduction program in Virginia, and I get tons of misogynoir every single day, right? This is like the basis of most of the presentations and lectures that I give at different schools, and not once, I never felt that during HepNET. So I know this was the right decision for me to make in working within this cohort. I'm grateful for you too, Bronwyn, because you and I have had a beautiful relationship through text, through emails. It was just right. It was cohesive. And I think I'm kind of getting off of the question, but this was right. I can't explain it. I hope I'm answering it just a smidge, but yeah, this was one of the best working experiences in the past year and a half for me. So, Bronwyn, I appreciate you and the rest of New Hampshire. I think everybody came and left their egos at the door. They checked a lot of different things, left it outside the door, and just brought their full selves to this work. So I appreciate you so much. Thank you.
That's great. Thanks, Dziko. I love hearing that. It's you've clearly set the bar very high for what it means to create a safe space and a trusting relationship. Trust came up a lot in the presentations and the themes that that you all talked about. So yeah, definitely for us to follow and maintain. Isabel, how are we doing on time? I know 4:17. Should we keep going? Should we wrap up? I'm happy to keep throwing questions at our presenters if folks can stick around. Let's wrap up. Okay. So I will hand back over to you then, Isabel.
Thank you so much. First of all, it has been like so wonderful for me to have a more background role in terms of what we've done for HepNet. I'm really sad that Jasmine couldn't be here to really witness how all the work that she led has led to more than what we anticipated. That being said, if y'all could fill out the survey to evaluate our VLC, we would greatly appreciate it. Thank you so much to everyone. We'll send out the recording with the questions answered in that email. Other than that, I appreciate y'all. Y'all take care. Y'all hang in there.
Thank you.
Bye.